Great. Well, hello, everyone. We have some more people coming in through the waiting room, but we have a jam-packed agenda today, so we're going to get started. My name is Stacy Chazen. I'm the Leadership and Education Lead with AIDPH, and it's my pleasure to welcome you to this month's Rural Oral Health Echo Call. I'm going to ask my colleague Jasmine Joseph to please share the slides for today, and we will get started. So today's session is on oral health for individuals with disabilities in rural areas. And we have a great speaker lineup and an interesting case to talk about today. So we're happy to have all of you here. Next slide, please. We want to begin by thanking our partners, CareQuest Institute for Oral Health, UNLV, and the Oral Health Progress and Equity Network. We couldn't do this without you. Next slide. So on today's call, we're going to have our didactic presentation on the topic of oral health and disabilities in rural areas. We'll have some time for a participant Q&A. Feel free to post your questions in the chat box or to raise your electronic hand and we will call on you. We're then going to have a case presentation. We're going to do some think tanking around ways to increase access to dental care for rural patients with intellectual or developmental disabilities, and then we'll close out. So today's call is being recorded. We ask that everyone please type their email and organization name in the chat for recording so we can keep track of who's here. And I do want to make sure, yes, we've hit the record button. Slides, forms, and additional materials that we're going to talk about today will also be available following the call on the AIDPH website. We ask you to avoid using any personal health information on this echo session. And if you have any questions about how to use Zoom during the call, please chat with Annalise in the chat box or with me. Next slide. Most of you, or many of you, have been here before for our echo sessions, so you're familiar with AIDPH. I'm not going to read the slide, but encourage you to visit our website, aidph.org, to learn more. About our Rural Oral Health Echo. This echo follows the CareQuest Institute's 3 domains framework using the lens of rurality and health equity to look at teleprevention, minimally invasive care, and integrated and personalized care. And the idea, as many of you know, is that you take the knowledge gained here back to your communities to implement ideas in your daily work and build the capacity of the oral health professional workforce in your communities. Next slide, please. Here's a reminder of what we've covered so far. If you missed any of these topics, any of these calls, and would like to listen to the recordings, you can do so on our website as well. And our last session of the year will be next month on the topic of veteran oral health. Here are our session norms. I want to flag just a few of them, including we ask everyone to both learn and teach. So please speak up, offer your guidance, please pose questions. We ask everyone to use first names to facilitate equality in the discussion. Please add your pronouns to your Zoom name and always introduce yourself when you're speaking. Next slide. So to get us started today, we are really honored and grateful to have Holly Seabury, who's Executive Director of the Delta Dental Foundation, to speak with us about oral health and disabilities in rural areas. Holly is Executive Director of the Delta Dental Foundation of Michigan, Ohio, Indiana, and North Carolina, which is dedicated to oral health equity and advancing dental science through education and research. She has over 20 years of experience in the nonprofit field. From 2009 to 2019, Holly was CEO of Macmillan Health, a nonprofit health education center serving more than 90,000 individuals annually. She holds bachelor's and master's degrees from Defiance College, and in 2015, she earned a doctorate in curriculum and instruction with a specialty in educational technology from the University of Florida. Holly, we're thrilled to have you, and I'm going to turn the mic over to you.
Thank you very much. And I do have to say, my doctoral dissertation was actually on rural oral health and working with Medicaid families with preschool age children. So this is a topic that is near and dear to my heart. And I've spent my whole career working in rural areas. And it's always amazing to me that the public perception is that the health issues exist in the inner city. That's what you always hear. And yet we all know that where the real problem lies with access and with transportation and with care is in the rural areas. Next slide, please. So this is an infographic about oral health and disabilities that was created by Project Accessible Oral Health and their All Smiles Shine project. I really encourage you to check that out if you have an interest in oral health and disabilities. But basically, we've got about 6.5 million people in the US with intellectual disabilities, well over 60 million if you count all disabilities. But I focus on intellectual disabilities because that is where the primary problem lies in accessing oral health care, is with intellectual and developmental disabilities. They did a study several years ago, and you know, I got asked one time by somebody like, well, why don't you quote a newer study? Yeah. Check out sometime the amount of research on oral health and disabilities. It's negligible. So yeah, your most newest reference maybe 10 years ago. But this study was parents who had a child with a disability, and they said it was harder to find a dentist to treat their child than it was to find a specialist to treat their child. That's, you know, unbelievable to me. Next slide, please. So this is what I really like to show people, is the intellectual disability mix. Often people tend to go way to the end of the bell curve. And the reality is the majority of people who have intellectual disabilities have a mild intellectual disability and can easily be treated in a general dental clinic with minor modifications. And honestly, if you take home nothing other than that fact today, I'll be really, really happy, because we have to end the stigma that people with intellectual disabilities can only be treated under anesthesia or at a specialty clinic. That is absolutely not the case. 85% of those with intellectual disabilities can be treated in the general practice setting with minor modifications. Next slide, please. So looking at disabilities and rural areas, 9% more likely to have a disability if you live in a rural area, 24% likely to have 3 or more disabilities. That's a profound statistic. And then social exclusion, that is a huge problem for those with intellectual disabilities in rural areas. They do not have access to the type of social programming that people who live in suburban and urban areas have. So then we see a lot of emotional impact on the intellectually disabled, which then, you know, shows up in their physical, on the physical side. Next slide, please. So nationwide, the average wait time for someone with an intellectual disability to get a dental appointment is 2 years. To me, that is a shocking and unacceptable statistic. In rural areas, it's longer. In the Upper Peninsula of Michigan, the average wait time is 5 years. I can't imagine calling my dentist and having them say, yeah, we'll see you for a cleaning and an exam in 5 years. And people always say, why is that? It's because of the limited amount of providers who will see this population. So when we have very limited providers, we're going to have very long wait times. In my state, they very inconveniently located both of the dental schools in the southeast corner of the state. That means if you are in the UP, you are looking at a 6 to 8 hour drive if you've been referred to the dental school, and chances are you have been, and a ferry ride or a very scary bridge or an airplane. There is no easy way to get there. You know, when they say you can't get there from here, yeah, well, getting from the UP to the dental schools is a little bit like that. Next slide, please. So this is the HPSA, the health professional shortage areas. You may have seen these slides before, but I always include them whenever I'm talking about rural areas, just because it's so astounding. These are the HPSA areas, and the darker the color, the worse it is. So when you see white is good. The dark blue is not good. So if you look at metro areas, yeah, there's a lot of HPSA areas, but then next slide, we'll look at the rural areas and we'll see how this map changes when we look at rural. Yeah, look at that. So this is predominantly where our problems are. Here in Michigan, we fight this every day, and in Indiana and Ohio, because these are all rural states that I work in. We fight this every day. We don't have enough providers. Transportation is an issue. Wait times are an issue. That is, the reality of what we're living with right now. Next slide, please. So in dental care, and I am, and you probably figured this out when you heard Delta Dental Foundation, I am the philanthropic arm of a corporation. I am actually a separate 501c3, but I'm funded by the corporation. And so I work corollary to a lot of dental insurance discussions, both Medicaid and commercial. And what we really do in dental insurance, whether it's Medicaid or commercial, is by and large, we give people equality. So I have the same benefits as the person in the office next to me. We have equal benefits. We need to stop looking at that and look at equity, and to understand that there are portions of our population that need more benefits. They need to be paid at a higher level. And that is the only way that we can achieve health equity. Now, we've done that here on our commercial side. If you have a family member with a disability, you get more benefits, like 4 visits a year, behavioral, the dentist can bill for behavior, desensitization, and it pays out at a much higher rate. So we're really trying on our commercial side to get health equity for our members that the commercial side insures. We're really pushing all dental insurance companies to do this. We really need across the board to do this on Medicaid and on private insurance. Next slide, please. So we work a lot in disabilities here at the foundation, and that's simply because my background is also a lot. I used to work in early intervention, supervising early intervention home visitors, and have developed a lot of curriculum and training over the years for early intervention. So I do have kind of an understanding of what some of the issues are with disabilities. So when we break down, so everything we do at the foundation, we are not afraid to tackle the big problems, but every big problem is made of a series of small problems. So what you really have to do is break down all the problems and tackle them one by one, except I tackle them all at the same time because I have no patience and I'm not willing to work through a whole list of problems. So we just go at everything all at once. But basically, when you look at the barriers to care for those with especially intellectual disabilities, reimbursement is a huge issue. It just is. Dentists have to be reimbursed properly for their time and their services. Education is an issue. Often caregivers, professional caregivers and family caregivers have not been taught how to care for their loved one's mouth or the people in their care. There is a huge awareness issue. When I mentioned to people that the average wait time is 2 years for someone with an intellectual disability, they're like, well, that can't be. I would have heard about that. Well, it is. And so we need to create more awareness, more advocacy, and we need to destigmatize this population. We do a lot of work around that. Training, most dentists, hygienists, and assistants have not been trained in how to treat this population. It was only required in dental schools since 2019 by their accrediting body, CODA. We need a standardized curriculum so that all dental schools have a baseline of excellence in teaching about this. We actually funded that curriculum. Spoiler alert. It's in development right now. It's a national curriculum. It's going to be amazing. We need hands-on training for the clinicians who are already out of school and in practice. And then we need innovation. We need a lot of somebodies to look at this problem in a very different way than it's been looked at before. We do a lot of, and I'm not this is public health in general. I've spent my whole career in public health. We spend a lot of time talking about all the problems. We need to spend a lot of time talking about the solutions to those problems. And we need to spend that time with funders who can do something about it, because that's how it'll change. So I'm going to talk about our innovation, Centers for Inclusive Dentistry. Next slide, please. So I was on the board for 9 years of a very large FQHC in Indiana, and I was president for 2 years. And I was doing a research study with families who had children with disabilities, and they couldn't find dental care. And so I started referring them to the FQHC. And I went in for my next board meeting, and I was thrilled. I was so happy. Like, I have a place for you to go. They'll accept Medicaid. They'll accept whatever insurance, the sliding fee scale. I was so happy. And then I got to the next board meeting, and they pulled me aside and said, "Are you referring families to us with children with disabilities?" And I said, "Yes." "Oh my gosh, yes." And they said, "You need to stop doing that, because we are telling them we won't treat them because we won't treat them." And I was really shocked to find that out. And that's kind of across the board. I was shocked to find it out because we just signed our big HRSA statement that said we wouldn't discriminate against anybody for race, religion, gender, and I'm like, well, how can you do that? And they said, well, we're not trained. So when we really looked at what would be the access point for this population, the FQHCs are a great access point because of all the things I mentioned above and why I was referring people there. However, when they say we're not doing this because we're not trained, yeah, they're not doing it because they weren't trained. So what we've done is develop a program that trains FQHC staff, both online and in hands-on immersive training, gives them the tools they need, gives them the resources and support they need. If they need equipment, we're supplying it. Not wheelchair tilts though, because one of the cool things about when they go for immersive training is how well they're educated on all the fancy equipment that you really don't need in a general practice clinic to treat this population. So basically, we're looking at strategically statewide identifying FQHCs who will come into this program. And we've actually rolled this out in our states. Creating access points through the FQHC system. And this requires a commitment of the FQHCs. For instance, our really great FQHC in Jackson, if you call in and have a disability, they fast track you to an appointment, just like they do when someone calls in with a child who needs an appointment, they fast track them. So they've made that commitment to this population. We're really looking to increase oral health and decrease emergency room care. There was a study done in Indiana, shocking amount. I think it was 30% of those with IDD had been to the emergency room in the last year for a dental emergency because they had nowhere else to go. 10% of them said the emergency room was their dental home. Just take a minute and let that sink in, that the emergency room is their dental home. All right, next slide, please. So basically, these are the big problems we're looking at. Limited provider availability. Dentists and support staff don't feel adequately trained, and they don't feel they have the comfort level to treat this population. Next slide, please. And this leads to limited locations for treatment. And I said this statistic before, over 85% of the IDD population can be treated in a general clinic setting. The statistic was 65% of people use the ER in the last year. That's shocking to me. And I've already talked about this, the wait time, the drive time. We need to strategically locate across the state locations where people can go. Next slide, please. So with training and support, we can do this. We can get these locations set up. The Medicaid wrap payment that the FQHCs get make this much more economically feasible for them. And they have a mission of public health, so it's a really nice fit. And the FQHCs we're working with have been really excited to be involved in this project. Next slide, please. So this is a slide of the immersive training. This happens to be a Penn Dental Medicine. Other immersive locations are NYU, which has the largest disabilities clinic in America, and coming soon, Ohio State University, as soon as the renovations are done. So it's online CEs and then 2.5 days in clinic doing immersive training. This is a picture of our first group out of Five Rivers FQHC in Dayton, Ohio. See the yoga mats on the wall? This is one of the really cool, I thought it was for staff. Like, do you stretch between patients? No, it's for patients. If you really can't go in the chair because of past trauma or fear, you can sit on a yoga mat and your provider will sit right down with you and treat you on a yoga mat. And that's the kind of techniques they learn. It's really, really cool training. I've been through it both at Penn and NYU. Next slide, please. So if you would like to do the online training, there are 27 free CEs that we've sponsored nationwide for anyone. If you're a dental professional, you get ADA CERP CEs. If you're not a dental professional, you can just do this for your own knowledge. But the website's on here, the QR code's on here. This, again, completely free. These are on demand, so you don't have to sign up on a certain day and time. And they are incredible courses. It's a national, it's not just Penn Dental Medicine staff, it is a national group of individuals doing this. Next slide, please. We also have, we funded the first app for autism and oral health to work on home oral health care and then prepare for dental visits. It is free. You just go under the App Store and put in All Smiles Shine, and it's a free download on both Android and Apple. It's cool. It's in phase 1. We'll be remodifying it. I don't think you can remodify. We'll be modifying it, and after our initial surveys from phase 1. Next slide, please. We are also rolling out momentarily a large amount of resources for home caregivers and professional caregivers. So they'll be available in print, in video. There's training available. Again, this is all at no cost, and this will be accessible to anybody who wants to access this. It was put together by a national advisory group, and really, really good information. Really excited for this to roll out because there are just so few resources for people who are caring for this population. Next slide, please. Oh, this is just showing videos. You can go, the same program, Access for All Smiles. You can go to the next slide. So this is where we're headed. And I want to report too, I'm really excited to report this. So this program, Centers for Inclusive Dentistry, is in Indiana, Michigan, Ohio. It is also rolled out in Illinois. In Virginia, they got a HRSA grant to roll this out. And in Florida, rolling it out with CareQuest monies. I just actually had a meeting with the DentaQuest dental director, Dr. Doug Manning, and myself, and all the FQHC dental directors in Florida about enrolling FQHCs in this program and getting our pilot group off the ground. So we are always willing to talk to anyone about either rolling out this program that we've got all set up, or any questions that you have about disabilities and oral health, or who's working on what and who to get in touch with. Always happy to answer those questions. We are really looking for a better solution, and this kind of outlines it. But we really want everyone to have a dental home and be able to access treatments and preventative care, and make sure that dentists are getting paid appropriately to see this population. And that's the goal that we're all working to. Next slide, please. So that is it. And Stacy, I'm going to let you know we are right now at 19 minutes and 30 seconds. So I did it.
Thank you, Holly. I told Holly she generally had more slides than we would want a speaker to have for a 20-minute slot, but I trusted that that she was going to be able to get through it, and she inspired full confidence in me. So thank you for living up to that, Holly. And that was terrific. I wonder if folks have any questions for Holly. And feel free to either put them in the chat or take yourself off mute. And while you're thinking about that, I do have one question. I wonder, Holly, if you could explain to folks who might not be familiar with the term, what the Medicaid wrap payment is.
Oh, yeah. So because federally qualified health centers are intended to treat the underinsured and uninsured, they get a bump in reimbursement to do that. Otherwise, they probably would not financially be able to do that. So there's what's called a negotiated wrap payment, and it's you get paid your Medicaid payout, whatever your state. And the thing to remember about Medicaid is every single state is different. They're different in what they pay, they're different in what they cover. But say you're here in Michigan, you get your base Medicaid pay for doing those services. And then you have, and it's different with every FQHC, a negotiated payment that you get on top of that comes from the state. And that payment is literally just to make it financially viable to see a patient mix that is predominantly underinsured and uninsured.
Great, thanks for that.
Hi, I have a question.
Great, can you introduce yourself?
Sure, this is Dima Algathi. I'm a grad student at the University of Iowa.
Thanks,
Thank you so
Dima,
much.
welcome.
Thanks for your informative information. It's really great to learn about things that we're not aware of, especially the CEN training. I just have a question if there's been any efforts like on the policy side to maybe like have training as a requirement for like licensure, or for it to be part of like programs in education, which you did mention there's like a statewide effort, but I don't know when that will be applied.
Are you talking about dental school or like?
Yeah, in general, like whether it's dental school, because I feel like we shouldn't be discriminating against people with disabilities.
Mhm.
So on the policy aspect, if there's been any efforts to try and help improve that.
Yeah, there was a big effort that resulted in the accrediting body of dental schools and hygiene schools saying that they do have to teach about disabilities. The problem is that, you know, that then requires each school to develop their own curriculum, and some schools are way ahead on that, some schools aren't. And that's why we funded the national curriculum, so that can roll out free to all dental schools. Now they may want to develop their own. And if you're a dental school like NYU or Penn Dental Medicine, you're a leader in this field. You're already doing this. Your students are all rotating through the disabilities clinic. But if you're not, this gives you resources to be able to start doing that. I totally agree with you though. This is a completely undertaught subject. And it's no better in primary care. They're not getting any better training in most cases than we have in oral health care. Yes, totally agree.
Yeah, thank you.
Thanks, Holly. So we have a question in the chat, and I hope I'm pronouncing your name correctly. Sundes Alfagi asked, similar to the yoga mat example, could you describe some examples of bringing comfort and trust to patients with special needs in the dental care?
Yeah, and so a lot of what we do is we help people create sensory friendly environments for the operatories that they assign that they're going to treat patients in. So it's a lot to do with, you know, kind of dim the lights, but first of all, ask what the patient prefers, you know, and do what they prefer. But a lot of it's communication, and it's, you know, it's talking to people, you know, about getting into the dental chair, not just shoving them into the dental chair, you know, and a lot of it's just being kind and considerate. There's actually not, here's what you find when you go through that immersive training. There's not any magic. There's no magic technique. It's really just talking to people, making sure they're comfortable, not proceeding unless you know they're comfortable. And so it really comes down to provider willingness, but it is really helpful, even though there's no magic solution. It is really helpful to watch experienced people do this and see how they do this and how you can take it home to your clinic.
Thanks, Holly. Beth Pierce, if you could introduce where you're from and share your question.
Hi, I'm Beth Pierce. I'm the Oral Health Program Manager with the Maine Primary Care Association. And interestingly, formerly the EPSDT coordinator for our state Medicaid program and a former practice manager. And this topic resonates with me, and I am so excited to hear what you had to say today, because along with access for children, when I worked for our state Medicaid program, some of the services we provided at the practices I managed were services to our special needs population. And some of that was in the dental practice itself, and others were under general sedation in a day surgical setting. And unfortunately, one of the providers that provided that service was only one of two in the state. He's not doing it anymore. So now that I work with the FQHCs, I see them, as you said, an ideal location for this type of care to be delivered, especially if anesthesia needs to be delivered by maybe a nurse anesthetist. So while I'm planning on some of my work this year is to offer training and more exposure like that, one of the things that I'd like to understand a little bit better than you had mentioned that you were referring people to your FQHC and they said, please don't, we're not prepared to serve them. Did you go any further than that to evaluate the population that was being served by the FQHCs in your state, or through any of the departments that to identify those that did not have access, that needed access?
Yeah, here's the problem. Most dental clinics, not just FQHCs, have no real effective way of tracking which of their patients have disabilities. And that's one of our kind of our guideposts in our Centers for Inclusive Dentistry program is tracking that in the electronic record, so you can pull that quickly. Access within every state is a huge issue. There are not a lot of great measurements for it. And I'll give you a great example. And before I talk about this example, I want to tell you, this is a very well-intended person. But she works for state Medicaid in one of my states. And she was on a call and she said, listen, here's the problem. We have no record of anybody who is a caregiver of someone with a disability not being able to find dental care. They don't call us. And we all kind of laughed and we're like, well, they call us, and so I put her, we're collecting stories from parents, primary care providers. So typically people turn to their primary care provider and ask where to find a dentist. And often they're sort of like, there's one person in the state, here's the referral. If they have a dental school in the state, here's the dental school referral. And I will say, we just funded a disabilities clinic at Indiana University. And I might have not been supposed to say that. We haven't done the press release yet, but whatever. But one of the things that the woman who's currently seeing that population said is it is so sad to her when someone comes in who's been waiting 2 years for an appointment, comes in and they're a perfect patient and they could have been seen by anybody in their community. And she said, that is heartbreaking to me to know that person waited 2 years and now they've probably got some real serious restorative work that needs done and anybody could have seen them. And so that's really, that's really what we're trying to overcome there, is that stigma of hearing intellectual disability and then just automatically saying, no, we won't treat this patient. But if you want, Beth, if you want any resources or want to talk about bringing training and resources into your state, I'm really happy to talk to you about that.
I'd be very happy. I just had a brief discussion with our policy team here at the Primary Care Association about the concept of identifying developmentally and intellectually disabled individuals as a medically underserved population in our state. And I know it exists. I can't quantify it to take it further because I've worked with those populations. And that would benefit our FQHC so much to be able to expand their staffing and their training to serve that population. but quantifying it is the challenge.
It's almost impossible to do that. The only way to do it is to do dual insured Medicare, Medicaid, but that in no way, shape, or form covers all of the people involved. But it's one way you can identify some of the people involved. This is the big problem, is that there's no way to track this population. So how do you advocate for a population that on paper kind of doesn't exist? That is the big problem.
Thank you, Holly, and thank you, Beth, for posing that. So I'm going to move us into the case presentation part of today's call, where Holly's going to be providing, I guess, we'll be partnering with our main case presenter, who is Ellen Shagru Hyman, which many of you likely know. She's executive director of the Michigan Oral Health Coalition, and is a really active professional in the world of oral health access, and has particular interest in meeting the needs of individuals with disabilities. So Ellen, I will turn it over to you to share with us the challenge here.
So when we talk, so just to follow up on Holly's presentation and kind of the cases she's talked about, or the type of people with this that have disabilities. When I think of people with disabilities that aren't served in Michigan, and Michigan is almost 100,000 square miles, 94% of it is considered rural, and about 20% of the population lives in those areas. And we have about 40,000 people, give or take, with intellectual and developmental disabilities that meet the definition in the state of Michigan that they're served by the community mental health system. And as my work in this area kind of started when I worked for a disability organization called United Cerebral Palsy, because people were calling us, looking for dentists. And often the only places we could offer that we knew about were, the U of M Dental School or Detroit Mercy Dental. So when I think of people with intellectual and developmental disabilities, and for a case study, I think of two different examples. As Holly said, most people with intellectual and developmental disabilities have very mild disabilities. So they might have some kind of cognitive disability, but they don't have a physical disability. And the stereotypical person that I think of that is, I had a friend who had a brother, and one of the biggest challenges with him is that, and this is very common with people with disabilities, they saw that the person got all their joy through food. So this person loved pop and would drink 2 liters of pop at a time. And they're like, we can't set any limits on that, because that's, he doesn't work. That's his joy. And so, trying to understand that this is a person that's probably going to need a lot of dental care, but can get into, can physically get to a dental office, sit in the dental chair. And then the other kind of person that I think of is somebody that maybe has cerebral palsy like I do, but much more significant. So they use a power chair. And so they might not, many dental offices might not be physically accessible. And even if it was physically accessible, they might not be able to transfer out of their chair. So while the yoga mat is a great example, how can we treat them in their chair? So those are the case studies I kind of wanted to talk about. I don't know if people have questions before we go into sort of the questions about how we can treat those individuals.
Any clarifying questions for Ellen before we move into her questions for the group? Okay.
When we did our state oral health plan a couple of years ago, we did have just what Holly said. We had somebody from a community mental health agency say we got people care under general anesthesia, and we used to do that every 2 years. So they would get their routine, their teeth cleaned and their x-rays every 2 years, and then it had switched to every 5 years. So just like Holly, I'm kind of horrified by the idea of people getting their teeth cleaned every 5 years. And I'm also horrified by the idea that the answer for a lot of people is we're just going to treat them under general anesthesia, because there's so many things that we can do that to serve people in a dental office without general anesthesia. So that's what we kind of want to talk about. So the first question is, what are some suggestions for increasing the willingness of providers to treat patients with intellectual and developmental disabilities?
So Ellen, we're actually going to go into some breakout rooms now for folks to consider these questions. And we'll be taking notes in those rooms so we can bring those back to you and Holly after today's session. So we're going to be in the rooms for about 15 minutes, and then we'll come back and have people, or I guess about 12 minutes, and have people share out their thoughts. We've also posted the questions in the chat box, which should follow you to your breakout room. So 2/3 of you will see an invitation to pop up to join a breakout room. The other third will be staying right here as your breakout room. So thanks for that, Ellen. And Jasmine, if you could unshare. Great, thank you. Okay, people are slowly moving through cyberspace. You know, and I wonder, it probably makes sense for Ellen and Holly not to both be in the main room. Let me see if I can move Holly somewhere. Okay. Great, and I am going to, but we can leave the recording on so we can continue to capture this room. So I'll ask folks to please put their cameras on. We find that these conversations are much more engaging if we can see everyone's face live. So if you're in a place where you can turn your camera on, please go ahead and do so now. Thank you in advance for that. Terrific. Thank you, Jeanette. Thank you, Liubov. I hope I pronounced your name correctly. David. Here comes Zill. Dalton. Look at that peer pressure, I think is working a little bit here. So thank you for that. So the asks that Ellen posed to the group are, and we can go through the list. So starting with, what are some suggestions for increasing the willingness of providers to treat patients with IDD? Are there suggestions folks can offer? And as soon as I see you raised your hand, so feel free to take yourself off of mute. And I think folks can just chime in too. We're a smaller group. So I appreciate the hand raising, but feel free to just take yourself off of mute and ask a question. Sundes, did you mean to raise your hand?
Yes, Stacy, hi. I'm sorry,
Great.
I couldn't open my video right now, but I have
That's
some
okay.
suggestions. Thank you. First, it starts, I think, with explaining the importance of providing this oral health care to underserved population, to the providers. We need to understand how important it is, how easy would it make their life, how would affect our lives in return, because those are part of the community, and if we help each other, everything gonna grow for all of us. The other suggestions that I have, of course, and it has been explained, like the training, like providing continuous resources and support similar to the All Smiles Shine, for example, app, something that is handy for the providers, like whenever they've face those situations like, oh, should I go back and revise the material that I studied before? Maybe I don't remember now, but if I have something very easy, accessible to me, while I have the patient in chair, that would make it easier. Especially because those group of people or those underserved population, we're not seeing them on daily basis. So we will forget easily what are the smaller steps that we need to perform. So that could help.
Great, thank you.
Thank you.
Other suggestions?
Yeah, hi, this is Dima speaking. I think an additional suggestion would be like having maybe a summary of tips of how to deal with accommodating them, and maybe screen ahead of time, because if a lot of them are on the milder end of a disability and they can be seen just like any other normal patient, why should we just tell them straight off, no, you cannot be treated here? Maybe that would at least have part of those with disabilities treated in the dental chair earlier on. And maybe those that need a referral because you don't have the facility can be referred elsewhere.
Thank you, Dima.
I dropped a few links, and there are certainly many more popping up all the time. Residency programs and experiences that focus on either hospital-based or outpatient geriatric special needs. Some of you folks are from Iowa, so you know well the Geriatric Special Needs Fellowship there. And they are working towards a specialty, so that's pretty exciting with Special Care Dentistry Association. So I think having a unified voice to procure guidelines and standards for this population will help sort of streamline a standard of care, so that it's not just, you know, what works in my hands, which is typically how dentistry works. But some of these links are your typical AEGD type general practice residency program. But there is a mini residency program that the Lee Specialty Clinic has for practicing professionals. I think it's like 2 to 6 weeks, and there are some others that have already been mentioned. But yeah, I would say the fear of the unknown and fear of complexity amid a already busy practice with staff shortages and things like that is probably what keeps most people away. So any kind of exposure opportunities all along training and practice would probably be my thoughts of increasing willingness of providers.
Thank you. What about, so the second question, what are some social determinants of health barriers that need to be addressed to get patients into care? And are there models to address those that can be replicated? Thoughts on that?
I think transportation, if you have a large wheelchair, mobility challenges, you require lots of equipment, it's harder to get you to your typical community dental practice. There are some really great programs out there that provide mobile dentistry services to adults with disabilities. I practice in Virginia currently, and the Department of Health has a whole program with a big bus that was, I guess it's like an RV, and they park it next to a group home, and they're able to provide care to folks in a more comfortable setting. I know Apple Tree Dental, who I work for as well, they have a mobile program into nursing homes and group homes as well, where they bring the equipment inside rather than a bus. So kind of that hidden copay, as it's known, the cost of transportation, cost of staff to accompany an individual, some of those barriers can be overcome through innovations like mobile dentistry or teledentistry, but it requires some interdisciplinary collaboration.
Are folks aware of any other models in their states or communities that are addressing either transportation or other social determinants that are particularly salient to this population?
I personally don't have experience with this as a grad student, and I haven't practiced in the US, but just as someone that does not have a disability, trying to find a dentist that will take your insurance is really hard. And I have private insurance that's good. So I cannot imagine what it's like for any other population that has other needs that need to be tailored towards. So I think just having a list of providers, I don't know what cost of care is for them, so I'm not sure if this is something that may be available at any institution or like a government entity that helps or deals with this type of population.
Thanks. That's a great point. I too have excellent private dental insurance, and my provider who I've been going to for 20 years recently stopped taking it.
Yeah.
And it's really true when you think about have that perspective.
Yeah.
Ellen, I'm curious, do you know how many states have a more extensive Medicaid adult dental benefit for adults with a disability than the general adult population? You're on mute.
I'm not familiar other than the legislate, or the policy that was just passed in Louisiana, that there's anything specific to people with intellectual and developmental disabilities that, or any more extensive benefits.
Yeah.
One of the things that I was thinking about, like in Michigan, which is not successful all the time, we have Medicaid pays for transportation to medical and dental appointments. But I don't know how many states do that. So if somebody doesn't have their own transportation, there's a variety of options for transportation.
Right, that non-emergency transportation, right? I see Asana has her hand raised.
Yeah, so I'm, my name's Asana, excuse me. I'm doing a pediatric dentistry and dental public health residency right now. And I've had some exposure working with people with disabilities. And I did do mobile dentistry in nursing homes for a few years in Texas. And I think one of the barriers really was just the nursing home politics. We might be contracted with a nursing home and then they change management, or they get a new social worker or something. All of a sudden they get contracted with a different dentist, and trying to get payment from nursing homes is a nightmare. And this is something that is completely out of the patient's control. Like Dima was saying, you're trying to find yourself a dentist, but when it comes to nursing homes, the people who are there, the residents of the nursing home, really don't find their own provider. It's just up to whatever the nursing home decides. It can be their provider, or it can be the company that's providing care. And so I think that's a really big barrier for patients. And it was frustrating to say the least. And I think that's a really big barrier, because they really just don't have a choice. They're just up to the mercy of whoever's in charge or administration or whatever.
Yeah, thank you. I want to give Jeanette has her hand raised.
Yeah, so Nevada is working on an IDD expansion waiver. So we'll be, I'm learning a lot from these conversations, so thank you. But one of the things we want to focus on as a barrier is sometimes there's a lot of paperwork, consents, medical clearance needed that some families might just not know how to navigate. That could be a barrier for them. So we're looking into hiring a care coordinator to work with the families and the caregivers to address things like guardianship forms, hospital registrations if they're going in for sedation. So that is one of the barriers we're trying to address.
That's a good idea.
Thank you. Everyone is flying back here. Well, thanks everyone. I know that in those of us who stayed in the main room, I think we ran out of time. We had a terrific observations and suggestions and questions that came up. I wonder if we could just go around and see if anyone wants to share anything notable that came up in their discussion, starting off with folks who were in the room with Annalise. I don't know what number you are, but hopefully you remember Annalise, because I think she was your facilitator.
I will bring up from our group, the thing that stuck with me the most was there are some resources available. There are trainings and resources available, but that it takes a lot of exposure in order to engender behavior change with providers. And so it's not just about creating the resources, but it's also putting them in front of providers over and over and over again, so that we can see change. And the second thing that resonated with me in our group was that change has to start early, which is in education and really training dental clinicians to not just didactically understand the needs of individuals with disabilities, but to also expose them to clinical care. I think to Holly's point, there's a lot of stigma around it. It may feel scary or ambiguous or unknown. And so direct clinical exposure during the education process early on is helpful to facilitating a more equitable practice and care delivery after the education has completed.
I would add to that also from our group was the comment around our training, such as those through the University of Pennsylvania. Do we have the outcome studies that say, number one, does it increase the care that is, increase the care, improve the care that's being delivered, and does it increase the engagement numbers of dentists who are participating in care for this population?
Thanks, Gail. What about from Caroline's group? Anna, could you share some of what was shared in that group?
Hi, everyone. We had a few different little conversations, and Caroline, feel free to interrupt me. Some of the suggestions as far as offering more assistance to the community was, I don't want to call it remote, but having support within the community with perhaps some telehealth models. And probably providing some restorative and minimally invasive care in different sites. And so having portable equipment to be able to support certain communities that are hard to reach.
Stacey, can you guys hear me?
I'm sorry, go ahead. I just heard somebody. Oh, Caroline, yes.
So I was not having audio issues in the breakout room, and all of a sudden we come back in and my audio is breaking up. So I'm not sure. Might be my Wi-Fi, but I just wanted to add, I could hear telehealth, I think is what Anna was talking about. But I wanted to add too, we talked about as far as a strategy for getting more providers to care for this population, really integrating the way that we care for this population between medical, dental, behavioral health. I'm thinking about standardization of care across a healthcare team where everyone can bring their own expertise. But the strategies and the tracking of this population, we talked about use of ICD-10 coding and tracking specifically, how we can work together as a healthcare team to really provide holistic care for this population.
Thank you. And what about from the group that I was with? Jasmine, would you share out one suggestion from the notes?
Sure. So some of the suggestions that we had were providers just need to understand the importance of how important this is and how important it affects the entire community, and also just reiterating it to that as well. I think the discussion was that these are patients that providers don't see every day, so people may forget how to treat them, how to, different tips and useful things they can provide for these individuals. So just reiterating the importance, sharing the resources, making sure it's not in the back burner, and that providers continuously understand it. Another suggestion was,
actually, Jasmine, I'm going to stop you. I appreciate the next, but I want to make sure we have time for the slides just to close out. So that was helpful. Thank you. And if you could show us the slides again, and while you're calling those up, I'll just remind folks that we'll be publishing on the website a summary of all the recommendations that were made across the 3 rooms today. So you'll be able to access those when they're available and read some more details about what the groups talked about. In terms of next steps, as always, CEUs are available for today's session. AIDPH will send out the evaluation and request form following the call. We'll also post the recording and resources from today's call on the website. We had a number of resources shared in the chat, at least in the breakout room that I was in. So we'll include those. Anna has posted the survey in the chat if you want to grab that now. Our next session is going to take place on November 30th on the topic of veteran oral health. So please be on the lookout to register for that. And if you would like to present a challenge to our group during that call, please also see the submission form on the AIDPH website. Thank you so much to everyone. Thank you to Holly and to Ellen in particular for leading us through your presentations today. I learned a tremendous amount. I hope others did as well. And thank you to everyone for your engagement, for the sharing of your ideas, and for your support of this program. And as a reminder, you can also earn a certificate in special topics in rural oral health. Please see our website for some details on that. Thanks, everyone, and have a great day. Bye-bye.
Thank you so much.
Thank you.
Thank you.